Working with Health Begins. And this meeting will be recorded, and that way, if you miss a piece or you have to leave early, don't worry. You can always come back and listen to the recording. And we'll go ahead and jump into part one, and we can keep going, which is just first and foremost to say welcome to everyone. We do ask that you update your Zoom name to include your name and your organization, if possible. That way we know who's in the room. And just to get things started with a little bit of participation, if you want to put in the chat a favorite spring flower or plant that you're looking forward to seeing bloom this season. I know most of you live in areas that, yeah, tulips, wonderful. Christina, yeah, most of you live in areas that have absolutely gorgeous natural, plant life. So I would imagine you have some unique ones. So we'll see what folks have got going on there in the chat. And then please, speaking of the chat, please use it throughout this meeting. If you're new, we use the chat throughout. So add questions, add comments. We definitely, want to hear from you, want this to be engaging. And let's see. Oh yeah, apple trees. That's a good one. Wonderful. Oak trees, lilacs. Yep, there we go. Wonderful. Thank you. Peonies, cherry blossoms are one of my favorites. Absolutely. Nice. Okay, thank you. Well, we'll go ahead and next slide, please. Again, just welcome if you're new. All of the slide decks, all of the materials are located for every session that we've ever done, are located in a shared folder. And so we will send this slide deck out after the meeting, and it has the link to that folder on this slide. So you can see all of the resources. If we said something too fast, don't worry about it. You can always reference back. All right, so today up at the top, we have some exciting, well, we have some news, and Eva, if you want to go to the next slide, please, which exciting for me and I think for Gretchen, which is that I will, starting at the end of this week, will actually be going on parental leave. My husband and I are adopting a little baby girl. And so unfortunately, I will have to bid adieu to this group for the year. But I am passing the baton. Thank you, everyone, for the congratulations. I'm passing the baton to Gretchen, who I know you will be in very, very good hands with Gretchen. And actually, Gretchen, do you want to come on and introduce yourself a little bit, tell the group a little bit about yourself?
Sure. Thank you, Gabrielle. And so excited for you. And my name is Gretchen Schroeder. I'm looking forward to working with all of you and continuing to support you all in the same way that Gabrielle has over the past year or so. I have been working in CalAIM since the inception and doing whole person care before that. So really love this kind of work, love working with community-based organizations and helping them figure out how to maneuver in this whole new world of CalAIM. And I do work with other collaboratives around the state, and so would love to learn from you all what's working here. And if I can, take those lessons and share them with other CPIs and take what I'm learning through other collaboratives and share with you guys if it is useful. So really looking forward to getting to know all of you and working with you. So I will look forward to doing this going forward. So thank you, Gabrielle.
Awesome. Thanks so much, Gretchen, and welcome to the group. All right. Well, I'm actually going to pass over to Eva, who's going to walk us through our objectives for today and a bit about our agenda.
Thanks, Gabrielle. So before we move forward, we just want to clarify our objectives for this session. By the end of this session, everyone will receive important updates about DHCS policy, align on and adopt our goals for 2024 for this collaborative, and provide feedback for DHCS on the implementation of housing deposits and the use of the community health worker benefit. And so a bit about what that's going to look like in our agenda for the day. After we kind of finish doing this level setting piece, we'll move into resource sharing. We'll talk about local feedback shared with DHCS, provide some policy guide updates, and reminders about funding and some local updates before moving into our planning conversation. Then we'll transition into the feedback portion for DHCS and then discuss next steps. And so before we move into providing updates and resources, we wanted to get everyone's feedback on planning for regional in-person sessions. We're hoping to do this in June or July, and we're hoping to get everyone's feedback about dates in June or July that you think would work best for having an in-person session in your county, dates that we should not hold in-person sessions if you're aware of any regional updates. And then if you have any suggestions for venues for an in-person session in your county. I think we've shared before that we're hoping to host a few throughout the region to make it more accessible to folks. So if you have any suggestions particular to your county for dates or venue, please drop that in the chat. Feel free to do that throughout the session, and then also to email us with any thoughts that come up around that. But now's a great opportunity. If anything comes to mind now, put that in the chat and we'll be sure to track all of those.
Awesome. Thank you, Eva. And Chloe, I see that you're on from partnership. If you can let us, if the partnership folks can let us know if there are any major conflicts scheduling wise in June or July. We certainly don't want to schedule things over other important things that are going on. Or, those of you that are part of other healthcare collaboratives or coalitions, please let us know if particularly if there are dates that we don't want to do conflicts with. So awesome. All right. So part 2 is our updates and resources. So first and foremost, is those of you who've been here for a while know that we've spent a lot of time over the last several sessions, and we can go to the next slide, Eva, talking about these 6 levers that DHCS identified as essentially priority areas for this year, and they had questions associated with each of those. So we've spent a lot of time gathering your input on some of the questions asked by DHCS, and we've summarized all of that input together into a document that we then shared with DHCS. So if you are interested in seeing the summary of that, we're including the link here. So you don't need to check it out, but if you're interested, please do. And certainly if there's anything that we got wrong, let us know. I believe we have submitted this to DHCS already, but we can always submit corrections. So again, just wanted to express a lot of gratitude for those of you that were part of those discussions. So thank you. And then the next piece is that DHCS has, let's see, we can go to the next slide. Thank you. So DHCS published some updates to the ECM policy guide last month. So the link to those is here. But we wanted to summarize some of the key points in terms of what has been updated. The first piece is that members will no longer be able to kind of double dip, so to speak, in terms of being part of an ECM program while also being part of a county-based targeted case management program. There are 2 exceptions to that. So there's a year-long exception for county-based case management programs that are for communicable diseases. And there's also an exception around for county-based case management programs, home visiting programs that are around promoting well-being for children and families. So if you work in one of those 2, I encourage you to go check out the specific language in the policy guide. We've included the page numbers so you get easy reference. And then for those of you that work with Medicare and Medi-Cal dual eligible members, there is an updated guidance around for dually eligible members who are part of a non-exclusively aligned dual special needs plan. And that has to do with authorizations that were approved last year, continuing to be valid basically for the next 12 months, so throughout 2024. And then finally, I imagine that all of you are already using the HCPCS coding guidance to bill for your services, but that is also a piece of the ECM policy guide, was just stating that the managed care plans must require ECM providers to build using the HCPCS codes. So if any of those seem relevant to you, I encourage you to go check out the ECM policy guide that's linked there. And again, you've got the page numbers, so you can go directly to whatever is most relevant to you. The other piece, we can go to the next slide. The other piece update from last month from DHCS is around the work that DHCS is doing to try to standardize the referral and authorizations process. They're looking at designing a standardized process for referrals and authorizations. What exactly that looks like, I truly have no idea. But the good news is that they're in the process right now of doing stakeholder interviews, both with managed care plans and with different other stakeholders, to try to inform what some universal ECM referral standards might look like. Their DHCS's goal is to draft their recommendations or their proposal next month in April and submit that to the CPIs so that we can then have discussions with you around kind of, does that sound good? What are pros, cons? What input do you have? So hopefully DHCS will be releasing that next month and in time for us to have that discussion for our next CPI meeting. And then finally, and we can go to the next slide, I know we talked about this last month, but just wanted to give a reminder to folks that DHCS has updated the TA marketplace, so the technical assistance marketplace website. It now has filters. I know some folks think that that makes it more confusing. Other folks think that really helps. DHCS made these changes in response to input they were receiving from the CPIs. But I encourage you that if you've looked at the TA Marketplace website in the past and felt overwhelmed, try it again. We've included the link there. You can filter now in some different ways. And you may find that, again, these are absolutely free services that your organization can use. So encourage those of you who haven't already applied for TA Marketplace support to go ahead and do so. It's completely free. All right, and then actually one final piece on updates is, we can go to the next slide, is I just wanted to create some space to see if anyone on this call had any updates around ECM or CS, particularly any updates that are specific to the Northeast region that anybody wanted to share with the group. And we'll continue to make space for this ongoing. But anybody know of anything that you'd like others on this call to know about? All right. Oh, Christina says we officially expanded to Tehama and Siskiyou counties. Great, and from Dignity Health. Congratulations, that's exciting. All right. Okay. Well, if you think of anything else, go ahead and put it in the chat. If not, we'll wrap up this piece. We can go to the next slide by just saying that a reminder that we are available to discuss all things ECM, CS, Medi-Cal transformation. So please, if you have any questions or would like some one-on-one support, we as facilitators are absolutely there for that. So contact us directly. We'll set up some one-on-one time with you. All right, and now we can jump into part 3, and this is maybe our meatiest section of today's meeting. We can go to next slide, please. And this is going to be a discussion around what goals do we as a CPI want to adopt for this year. The the goal for today is to align on what that goal or goals should be. So please speak up, raise your hand, come off mute, share your thoughts. Please also feel free to use the chat if you'd rather write things down. And if you have things that you don't want to share publicly, but you'd like to be considered, please go ahead and email us. We always are interested in that kind of feedback as well. And so with no further ado, we'll jump into that discussion. So the way that we've structured this, and this is the way that that PCG, which is the contract administrator for the CPIs, structures this, is essentially that they ask that the CPIs have an overarching aim, and then like primary drivers of change that go under that. So kind of basically an overarching aim and then goals or activities that are going to kind of support that aim. So based on the feedback that we've gotten from this group so far, we were thinking that it made sense for the overarching aim this year to be around increasing ECM and CS utilization in all of the Northeast areas, but particularly in the counties for Modoc, Lassen, Siskiyou, and Trinity, because we know that Shasta is already certainly can be increased, but there's already a lot of activity going on. So we wanted to think about how we can also better support those other frontier counties. And let's go to the next slide. So the first kind of question for discussion is, do folks think that that should even be the aim? Like, is that the right goal for us to all have? But then the second question is, what percentage change should we be aiming for? And we want to set something that's both ambitious, but also that's reasonable, right? We don't want to set ourselves up for failure. My assumption is that Shasta County may need a different percentage change goal than the other counties, but I am welcome to be told I am wrong on that. So here you've got the data for each of our Northeast counties, what the Medi-Cal population is, the estimated ECM population, and this is very rough. So this is 2% of the Medi-Cal population. Where that comes from is that DHCS has estimated that between 1 to 3% of Medi-Cal folks may be eligible for ECM. So we just split it through the middle, said 2%. Again, this is very, very rough. The ECM utilization, so what percentage of members in that county, Medi-Cal members in that county, are currently using ECM services. Now, a huge caveat on this data is that this is as of June of last year. So there's a major delay, and that's because we are working with the data that DHCS has made public. You all may have more accurate, up-to-date data. The rough number of ECM members who are currently receiving ECM, and then if our goal was 2%, how many more members in each county would need to be receiving ECM to meet that percentage. So I'll open the floor to thoughts, comments, ideas on one, again, is increasing utilization, is that what we should be striving for as a group? And if yes, then what do folks think is a reasonable kind of percentage change that we could set as our goal, or any considerations around that? Yeah, Amber?
Sorry, I wanted to make sure I was off mute. I would like to see for Shasta, I have to give some thought to like the percent, but maybe not so much increased utilization, but effective utilization. Right now we have a lot of providers and we're all kind of working for the same people. And it's, so I just would like to see like some streamlined with that.
Yeah.
I also think in terms of helping out our frontier counties, I think it would be awesome if we were able to do some site visits and like really kind of just do some thoughtful exploration, because what MODOC has available to like refer out to is going to be just so different. And we could also look at what natural partnerships might exist in Shasta that are closer to the frontier counties that might be like a good way to start like expanding capacity for those frontier counties. So, I mean, I always think, you know, Zoom is great, but, you know, and you talked about where to meet, like maybe, you know, looking at what something maybe a little bit more central for those counties, and we could, you know, do some like breakout sessions for them. But that would be my thoughts for Shasta.
Thank you. No, those are great. And I, in particular, in thinking about doing site visits, the goal this summer is actually to, yes, do a CPI meeting in Shasta County, like probably the Reading Partnerships Reading office like we did before, but to also do a CPI session in each of the other counties. And so to the extent that we could do those at different relevant sites, I think that would be a great idea. Andrea and Toby.
There we go. Hello, all. Just to piggyback off of Amber, I definitely agree with her, but I also think it might be difficult to launch these ECM services in these other counties due to the lack of member resources there. I feel like that's a big barrier. So if there can be a joint partnership, as Amber was talking about, I definitely see a rise in utilization in those counties. But we'll have to figure something out. There's just not enough resources in those counties to provide all the services that are, you know, entailed in the ECM. So that's all I have to say.
Thank you, Andrea. Yeah, and I think that in the next couple slides, your comment is right on point in terms of what activities might support this increase in utilization. So thank you. Eric?
Hey, thanks. I'm curious how DHCS or whoever collected this, what source they were using, particularly with Change Healthcare being out. If this is claims data, there's no way that there'll be an accurate picture of the volume of services in the next few quarters until all the fallout from the breach and the clearinghouse is resolved. None of the providers who are using that clearinghouse are able to batch out claims right now, and so it'll just I don't know that anyone's going to get an accurate picture over the next quarter or two.
Yeah, thank you, Eric. That's a really important point. And I think this data that's on here predates the changes breach, but you're absolutely right that any data that we have now, there's likely to be a claims lag. So I wonder in that case whether, and our partnership folks on the call, I don't know if maybe having data on authorizations might actually be a more accurate estimate of who all is getting services. Great. Any other thoughts on whether kind of this as a goal makes sense or not?
So, I mean, I think it always makes sense to be looking at increasing, right? But I think it depends on, like, to look at one whole county increasing by this whole amount, that doesn't speak to the unique, like we have some really small nonprofits. Yeah. And then we also have some like really big folks in the area who are able to take in large capacity. So, and like, I totally agree with Andrea's point around like, you know, frontier counties are going to need to look at what's reasonable, because otherwise they're selling a service to a client, to a human that they can't stand behind, right? So I would encourage DHCS, pardon me, my brain stopped on me for a moment, but really we should be looking at like more individualized goals. So like, we're working right now at Schutzme Health Center about how do we screen our referrals, and what would it look like if we screened 5% more, because we know we have to typically screen about like 80 to get 10 in, right? So we're, you know, so I think I understand the QPI mindset, but I think for some of this stuff, we're just going to have to look at more individualized instead of just like across the board asking one whole county to do more. If we set it like that, it's going to be about quantity of service, not the quality, and you're not going to get those long-term cost savings that like, you know, us on the ground, we want people to be better because it makes our community healthier. DHCS, not that I don't believe they want that, but they're looking at cost savings, right? And so if you put the focus on quantity of referrals, that is not going to get you quality of work. And it's going to set smaller counties up for failure. So that would be my like overall feedback on that.
Yeah, Amber, that's super helpful. I'm in thinking about kind of what would like if we shift the focus to be on kind of effectiveness, like you were saying, of referrals or of services or of local coordination among the different ECM and CS providers, and in kind of thinking about more individualized goals, do you have any ideas about kind of how we might shift that aim? Like what would be a more helpful overall aim that might, for this group, that might be more about quality rather than quantity?
I'd want to brainstorm some more, but like off the top, I'd say like we could look at like, yeah, we could look at increases. We could also look at like social determinants of health. We could look at quality of care plans. You know, like we could look at, you know, I'd want to play around with it because again, if you're using short-term post-hospitalization as a way to fund outpatient treatment, that's going to be a different quality goal than if you're using it like we use it routinely to like strengthen people's chronic health. So
right.
Yeah, Christina has a good one there too.
FTE increase for LCM. Percentage of eligible people identified by the MCP that are receiving services. Okay. Yeah. Good. Okay. These are really helpful. Any other thoughts on if we moved away from looking at an increase in the number of services, what other kind of measures we could use as a group to look at either kind of local coordination or quality of services being provided? I imagine that. No worries, Amber. Thank you for participating thus far. Let's see. Are all populations of focus being provided in each county? Yeah, Christina, that's a really important one. Tim says lower readmit rates would be a good indicator. Yeah, that's true. That's fundamentally part of the overall goal, right, of ECM and CS is lower readmit. Yeah, great. Okay, wonderful. Well, let's keep those in mind, and I'll move us to the next portion of this discussion, which really speaks a lot to some of the things that Andrea and Amber were just sharing. So these are the kind of drivers of change or just ideas on things that the group could work on that might work toward that ultimate goal. So these were just ideas that I had heard from this group and tried to summarize, and we can go into a little bit more detail. So, but again, this is just a first draft, so would love input on one, kind of what's most important. So what's the priority? And also if there are some of these that you're like, this is not like, this is not what we should be focusing on. So one driver is the kind of that piece that Amber was saying about local coordination. So provider referral coordination, trying to make sure that the right members are getting matched with the right providers that specialize in their population. So one piece of it is streamlining provider referral pathways. Certainly another piece that I've heard from this group was around strengthening local relationships and coordination. And then also definitely a role that this CPI plays is wanting to facilitate peer-to-peer support. So, you know, to the extent that you all can learn from one another about what's working for your agency and your population. We really want to be a source of facilitation for that. And then the other driver of change that I had heard was a desire for expanded provider capacity, and less so in Shasta with ECM providers, but more in those other frontier counties. So identifying potential existing like entities, existing organizations that might be able to become or might be able to offer different CS services, as well as taking some of the learnings that Shasta County has had, both with whole person care and with ECM so far, and seeing like what of that makes sense in the context of the other counties in this region. So I'll do 2 more slides of just kind of more detail of each of these ideas, and then definitely want to get the discussion going in terms of what your all's thoughts are on these. So Eva, can we go to the next slide? So I apologize that this is so much text, but again, these were just ideas that I had heard you all uplift over the course of our different discussions. So in terms of streamlining provider referral pathways, one idea had been like finding some way, whether it's in point-click care or some other local resource, that you all could easily identify what populations of focus each ECM provider served. Another idea was trying to clarify the difference between ECM and other waiver programs like MSSP for providers and members, to make, you know, kind of deciding what program to be in a little easier for folks. Certainly like holding at least one in-person session in each Northeast county. So we're planning on doing that this summer. We want to be hosting peer-to-peer support sessions, so we will continue to do that. And then we will also continue to compile and share promising practices. So things that you all are doing that are working for you that you think might work for other organizations. So actually, why don't I pause there and just say, in terms of provider referral coordination, what are people's thoughts on like, is this type of stuff, is this what we want to be doing with this group this year? Or are there other priorities that you all would like to see? Or maybe we've completely missed the target and none of this is relevant.
Jamie, please call 1224. Jamie, 1224.
I think this is all great for us to focus on, because I know in the previous CPI meetings that we've all had together, like these were the big focus areas that we all talked about before. So I support all of these things,
Okay.
but also we are providers of a lot of those other waiver programs. So of course my motivation is going to be a little bit different maybe than other people. And I hear it all throughout the state, whether it's the adult day health centers that I communicate with or other MSSP programs that I communicate with. Everyone is really struggling with this idea about ECM because they just see it as one new case management program and they don't understand the differences and why it's another benefit for our population. So yeah. I think it's a huge statewide thing that needs to happen, not just inside of our community, sure. But that's just my circle.
Yeah, thank you, Christina. So does that particular activity of trying to create material to clarify the difference between ECM and other waiver programs, does that resonate with other folks? I know that for some of you, you don't work with populations that are as affected by that.
Yes. I would appreciate that too. We have some regional center programs across the state. Try and stick some ECM staff there and it gets complicated.
Okay, perfect. Great. All right. Okay, so I'm hearing general support. Roxanne, thank you for the comment. Let's see, Tim shared, I like these topics for our frontier counties. Let's also try to include organizations who aren't directly providing ECM services, but maybe a good resource for local referrals like Modoc Medical Center. And yeah, absolutely. Absolutely. Thank you. And let's see, Andrea, I think this lineup is fulfilling for our needs regionally. Wonderful. Okay, great. So then we can go to the next slide, which is a little bit deeper dive into that second driver of change around expanding provider capacity, particularly in the non-Shasta counties. So one idea in terms of identifying potential local providers was to work with the local community resource centers. I know this was an idea that's been uplifted by this group before, in those frontier counties, to identify opportunities for them to become potentially ECM and or CS providers. Another idea that we've talked about a little bit was exploring like just what local organizations exist, or are there kind of unofficial resources that could be, with the right supports, could be transitioned into ECM or CS providers. And then the other branch of that was trying to take some of the learnings that you all working in Shasta County have had and seeing how they may be able to apply in those other frontier counties. So looking at, the promising practices, particularly around provider capacity expansion. And then also for those of you that are involved in Shark, kind of what are those best practices or learnings that you all have had that might be good recommendations for some of the frontier regions. So what are folks' thoughts on this in terms of whether these sound like the right things for this group to be working on this year?
I apologize in advance if you hear a fire alarm going on. They're just testing our system. It's totally fine. But anyways, one thing that I think about when I'm thinking expanding the provider capacity is making sure that we can kind of provide training or enrichment for the lead care managers, right?
Yeah.
If they are more effective at their roles in general, then they can have more capacity on the individual level than maybe somebody who's not as trained or familiar with this particular situation. So when I'm thinking expanding provider capacity, because we're expanding to new counties and whatnot, that we already have sites that are locally represented there, I'm thinking about ways that I can provide training for CHWs, or making sure that we can provide a good learning opportunity on case management services in general, which helps then increasing provider capacity. So that's where my focus personally is in these things. And I think all of these other things will help support that too, but that's where I'm personally driven towards.
Yeah, Christina, thank you for that perspective, because that's so important. It's not just about adding additional case managers, but it's also how effective are those case managers individually, and being able to make sure they have the right training and support. So thank you. That's great. Shelley? I saw you go off mute, so I wasn't sure if you had something you wanted to add.
No, I didn't. Thank you, though.
Okay. All right. Any other thoughts on whether this makes sense as things that we want this group to be working toward, or anything else that you're not seeing that you'd really like for it to be a priority? All right. Well, if you think of anything else, send us an email or put it in the chat. And we'll wrap up with a couple of polls really quick. So the first is, do you agree that the CPI's aim should be to increase utilization? Now, we've had a lot of discussion about how that's actually maybe not the goal. So, but we would love to get just kind of a sense from folks of, yes, that should be our overall aim, or no, we should really be focusing on something else. Maybe it's local coordination, maybe it's quality of services and looking at indicators for that. And if you have specific ideas, you can add them into the chat as well. And if I've lost line of sight on our poll, so I don't know where we are in terms of if.
We have about 70%.
Okay, you want to go ahead and just publish? All right, so it sounds like we have some more discussion to do. We've got a 28% yes, 33% no, 40% not sure. So, all right, great. Thank you, everyone. We will come back to you with another proposal, and we'll go from there at our next meeting. All right, the next piece is which of the drivers of change that we talked about do you think are most important for the CPI to focus on? And so the goal here is to pick 3 of what do you think. Oh wait, I'm seeing that it's set up. Okay, never mind. So just pick one. Do you think that it's most important to focus on provider referral coordination or to focus on expanded provider capacity, or something else? And Eva, again, I'll defer to you on sharing the. All right, should we share the results? Okay, this is helpful feedback. So it looks about 75% of folks want to focus on provider referral coordination and 25% on expanded provider capacity. So it's really helpful. Great. All right. Well, now we can move into our other discussion topic, which is DHCS asked questions about 2 different topics. So we can go to the next slide. So what you share here will be summarized and packaged up and shared with DHCS. So again, encourage folks to speak, write in the chat, send us an email. Let's go to the next slide. So the 2 topics that DHCS was curious about getting local feedback on, one was about community health workers, or CHWs, and the other was around housing deposits. So in terms of CHWs, now we know that the ECM benefit can't use CHWs, but we also know that many of you are likely using community health workers for other parts of your program that may be interacting with the ECM parts of your programs. And so we were curious about in what ways you're kind of weaving that funding, or in what ways you have CHWs as part of your organization providing other services, maybe to the same populations that are also receiving ECM services. So does anybody currently employ CHWs and bill them under the Medi-Cal, or bill them to partnership? And how do you kind of weave that together? Okay, interesting, Christina. So you have CHWs, but not billed to PHC. Okay. Can I ask why?
Yeah. So what we have kind of done is we wanted to utilize the community health worker as a expert in what they do as lead care managers. And so because of that, we're not billing for it separately, because that would be duplicative billing.
Right. Okay.
But we think that the area of expertise that they really can provide in what they do is actually more beneficial in that role as a lead care manager than anyone else that we have found to fill that role. So what we have done is we hire people who don't have necessarily the CHW, but we actually train them in being CHWs, so they get their certificates as a CHW. But we're not contracting with partnership or setting anything up or billing anything separately to partnership, because we think that skill set is what's most important than getting the additional funding one way or another. But it doesn't mean we won't in the future separate that out, but as we've gotten things started and really moving in the right direction for our program, that's what we have found to be most effective to make sure we're doing the right thing for our community.
Yeah, yeah, thank you. And I think if I remember correctly, that Amber had spoken in a previous session about kind of a similar staffing model of using folks with more lived experience and focusing that in terms of the case managers and then training folks up. Great, thank you. Is anybody else either using that same staffing model of kind of using folks with lived experience who may not have licensure, but then training them up as kind of CHW type case managers, or are you using CHWs in a different capacity in your org?
We looked at the rates for CHWs and we couldn't make it work. So I don't know that that's something that's in the cards for us.
Okay, that's actually really helpful input though, Eric. So thank you for sharing that. Yeah, I mean, the dollars have to make sense, right? Yeah. Yeah, Andrea. Okay, thank you. So it sounds like the reimbursement rate keeps folks from using that. Okay. Roxanne says, I'm not well versed in the CHW benefit, but curious to know whether the CHW benefit provides funding from the state or MCP. So yeah, so I'm definitely not an expert in this, but there is a Medi-Cal covered benefit for CHW provided services that you can bill the health plan for certain services that are provided to your members by a CHW. The key thing is, though, that can't be part of the ECM program. So you can't bill for ECM and bill for CHW services for the same service for that member, because it would be double dipping. But like what some folks do, we were talking to a provider in, I believe it was Stanislaus County, where they use CHW folks to do kind of some of their community outreach and bill that, and I think they also do health education groups with their CHWs. And then those folks refer people into their ECM program, and then they provide ECM services separately. So that way they're getting kind of funding from both benefits. Okay, Katrina Fermenta.
Thank you. Yeah, that was very helpful. Thank you so much, Gabrielle.
Yeah, absolutely.
My understanding is that you can bill for them being in ECM, and then you can bill for the CHW separate if it's being provided as an added benefit on top of the LCM, right? So if you're thinking of them as a specialist that is providing the additional support on top of what their normal case management is, then you can bill for that separately. But otherwise, if they are your lead care managers, that is duplicative and you can't do that. And I noticed that Tim had made a comment in here too, since FQHCs are not allowed to bill for CHWs. He found it interesting, the model that we kind of tackled, so that we were providing that level of expertise and then providing the service differently.
Yeah. The other thing, Roxanne, that we can share out, so maybe Eva, we can make a note of this, is the all plan letter about this benefit, because it details out a bunch of services that CHWs are not allowed to, or I shouldn't say it that way, that you're not allowed to bill for under the CHW benefit. So that might be helpful if you're thinking about using that model to just kind of see what the limitations are. Great. Okay, great. And then the other topic was around housing deposits. So DHCS was interested to know what barriers or challenges folks are experiencing with using housing deposits and how you're currently navigating those barriers, particularly if there's anything that you would like to see differently or be different, either in terms of DHCS policy or from PHC. Yeah, kind of what would that be? So how are things going? Yeah, Eric.
Yeah, this one's I never decline to comment on housing deposits. There needs to be an administrative fee reimbursed to the provider of these services. There isn't right now. I imagine the same thing is going to happen with transitional rent when that goes live and whenever. And not every organization that provides housing deposits has the facility itself, so collects the full payment amount in a backwards sort of way. And so when we execute a housing deposit, there is a cost associated with us processing checks and delivering it and so on and so forth. And we just pass through all of those right now. We are effectively paying the health plans and DHCS to provide this service. And it really, it's unfortunate that it's structured that way.
Yes, I hear you. So having a separate administrative fee to compensate organizations for that administrative work that they're doing. That makes a lot of sense.
Yeah, thank you.
Great, thank you. I've got Tim, would love to have some documentation and resources that I can use in my discussions as it relates to weaving funding. Okay, yes, we can work on that. Thanks, Tim. All right. Any other thoughts on housing deposits? Kind of, how's it going for those of
I
you?
would echo what Eric said about just that administrative fee for providing it. We're not currently providing it with partnership, but we are with other plans across the state. And the other thing we've seen is different plans have different reimbursement timelines. So trying to keep track of who's going to reimburse in 30 days versus a 5-day turnaround, and knowing that we're carrying that fee and waiting for the reimbursement without getting any type of compensation for that is a challenge for us, we've noticed.
Yeah, Katrina, thank you for uplifting that, because that's something we've heard in other regions, that particularly for smaller groups as well, that not having really timely, fast turnarounds on the reimbursement really is rough for organizations. So thank you for sharing that. Andrea?
Thanks, Toby.
Hi, Toby.
Yet to find a property management company or a landlord that's willing to wait till a TAR is approved to accept. Usually they got a small window that they're willing to hold the apartment for, or house for a member. You know, they don't want to. Some of them want to promise to pay, but we don't want to do a promise to pay just in case something does fall through. So that's a barrier too, is that real small window. Sometimes they give them a couple days to come up with that, and we won't do any of that until we get a TAR approval. So that's a barrier. Sometimes they lose housing on that too. So
that's a really, yeah, that's really helpful. So it's the timeline on the front end with getting a response on the auth, and on the back end in terms of getting payment, it sounds like.
Correct.
Okay.
yeah, they don't want to hold it, you know, because that's they're losing income when they hold that.
Yeah, of course.
Open for you know, week to 10 days to get the approval and a check to them, all that stuff. They don't want to hold the apartment for them. So yeah, but I don't think there isn't a lack in Shasta County of people looking for housing. So
yes,
you know, they're not just go from one to the next one saying, okay, if you don't have the money, then we'll just go to the next person that's been approved. So
yeah, that makes a lot of sense. And I'm seeing that Tim is saying, sounds like there's an opportunity for fast tracking deposit related requests. Yeah, Tim, do you want to voice over on any of that, since you're bringing the perspective from partnership?
Well, I'm just kind of thinking out loud here, and we've got Chloe on the call, who's definitely more of a subject matter expert in this area, or at least I saw her earlier. I don't know if she had to hop off. But it's just something that I'm glad is being brought up here, because it's just, you know, otherwise not something that you typically think about is, you know, landlords are itching to get these filled as quickly as possible and aren't typically going to wait a really long time. So I think that it's just good that it came up, and it's something I can certainly review internally with our CalAIM team.
Awesome, thank you. That would be great to have some follow-up on that. Thank you, Tim. Great. All right, well, I know we only have a few more minutes, so I think we'll go ahead and wrap up with, we can go to the next slide, just with a poll of what was most valuable today. We always like to get a pulse check on that. Was it the updates from DHCS, our discussion around what the goals of the group should be, or the discussion we just had on CHWs and housing deposits? What piece was most valuable for you? And again, I will defer to Eva on running our poll here. Okay. All right. So it looks like mostly it was our last discussion at 50%, and then 38% of folks saying the goals discussion. All right. Great. Super valuable. This is really helpful as we think about agendas for future sessions. All right. I'm going to pass over to Eva to wrap us up. Let's see.
Thanks, Gabrielle.
Yeah.
So for next steps and to things to think about ahead of our next session, our April session is taking place on the 23rd. There will be a registration link shared in the post-event email, as well as on the calendar invite. As always, continue working on your PDSA, and please reach out to us if you would like to meet with us for a one-on-one. For any additional support, we're always available to meet with you. And then we're holding our office hours right now directly after this meeting with Visions of the Cross. So please feel free to just hop over to that other Zoom if you have any questions that you'd like to have answered in those office hours. And the same thing will be happening for the April sessions as well. But I think that's about it. Thank you everyone so much for your engagement. And I'll pass it over to Gabrielle for any closing thoughts.
No, that's it. Just thank you, everyone. Since this is my last session, I just want to say what an honor and a pleasure it's been to getting to know all of you. I continue to be just blown away by the work and the passion in this group. You're doing just remarkable and remarkably important work for the folks in your community. So just a lot of appreciation to you. And yeah, that's it. Well, next time you will be in good hands with Gretchen, and hopefully we'll see some of you over in the office hours Zoom. So thanks, everyone.
Run.